Well, according to WHO, palliative care is incomplete if we don't have the physio component or the palliative rehabilitation. And when we're talking about palliative rehabilitation, we're also including physiotherapy, occupational therapists, speech pathologists. All these three professions are included, but the emphasis has been more on physical therapy. So the role we play is technically improving the quality of life at the end of the day, and be patient advocates as well. Not all patients is the same. They don't present the same way. They don't, depending on what diagnosis they have. They could have had a cancer of the breast. They could have a cancer of prostate. They could have had CVA, strokes, Parkinson. The range of what we do in terms of rehabilitation and palliative rehabilitation is very wide. So the presentation of what we do to a patient depending what they present and what are their needs, because ultimately we have to work with the patient and the family to tailor what exactly they want to achieve. We don't set goals, the patients set goals. So in other words, it's a collaborative approach, including the medical profession, like the physician, the other nurses and social workers. So we address the issues that the patient or the family wants us to address, such as pain. And in pain, for instance, we can be as simple as using an electrical stimulation, we'll call it TENS unit, for pain control, which reduces the dependency on pharmacological needs. We can also, sometimes just changing of position can alleviate pain. Sometimes using an assistive device or a prosthetic that can reduce the distress or pain. Sometimes it's just teaching the caregiver and or the patient on breathing techniques that can, it depends. So whatever the problem comes, there's nothing that we cannot do to alleviate it. So mobility is one, pain control, fatigue, energy conservation techniques, lymphedema, the swelling of the limbs, or edema, whatever that may be, from either cancer complication and or from venous insufficiency, where patient develop wounds and swelling on the lower legs. So those are the most common ones that we see in palliative rehab. The wonderful thing about physio is that we are in terms with physical, we touch and feel, and that proximity we have with the patient allows us and allows the patient to feel comfortable as well as confident to share whatever they're experiencing. We don't see a patient just as, okay, this patient needs help to walk, or this patient needs help to bathe or to be comfortable in breathing. We see a patient as a whole being. The patient is a physical component, there's a psychosocial component, there's a spiritual component, and we try as much as possible to work collectively. If something we cannot do, we cannot help a patient, we refer. And the sources of referring is really important, and establishing that teamwork is critical. I can give you a couple. One is a very simple one. I remember I came here and I was working with Jackie. We went to a patient who was in a lot of respiratory distress. The patient was sleeping in bed, just without any support on the head. And she was breathing hard. And sadly, it was towards the end of her life. So we made a difference in that patient's last few days of life by just helping in positioning the patient, making her sit more upright. And it was an instant relief, and not only for her, but also for the family that was around her. So that is one simple one. Again, just telling you, just positioning can make a difference. But another time is I had a patient who had head and neck cancer, and it was a recurrent cancer. And we worked with the patient, and to a point where he wanted to make it to where his daughter was getting married, that he wanted to attend the wedding, even though he had stage 4. But we were able to help him gain strength to be able to walk his daughter to the altar. And so that was, to me, was heartwarming, and he really did express that gratitude, which for us it was an honor to be able to do that. One of the things sometimes is the lack of the community, including physicians, not understanding the concept of palliation. They think this is end-of-life care, whereas it is not. In palliative rehabilitation, you have a spectrum of patients. Some will get up and be totally curative and live their lives for the next 20, 30 years, however. It's determined by their maker. And the other times, the challenges are really important in addressing the misconception of the term. That's the most important. And then thinking, well, I mean, somebody's going to die, so why should we pay for physical therapy when someone is dying? But even if they are going to die, I mean, we're all going to die ultimately, but the quality and the dignity of that person towards the end of life is also critically important. So when we say palliative care, we see patients who are like, let's say, if we take cancer, stage 1 or stage 0. They go through surgery, we make sure that they're able to move their arms, we make sure that they're breathing well, we make sure that they understand the concept of therapy in terms of exercise. We talk about nutrition, the whole gamut on how to live a balanced life, life and work, leisure and work, And also, we can see patients who are towards the very end of life, stage 4 cancer patients. But they still, just because someone is stage 4 does not mean that they're going to die tomorrow, or does not mean that they cannot benefit by increasing their independence till the very end of day. For you and I'm going to ask you a question. Won't you be interested or wanting to maintain your independence until the last minute? Yes. So why should we not extend that and enable patients to have that quality of life until the last minute? So the challenge is not understanding the concept. And I'm hoping that Ireland right now, by establishing the palliative rehabilitation, will take the leadership in moving the palliative rehab, integrating into the Zimbabwe health system, but at the same time comply with what WHO requirements are. Palliative rehab has to be a component of palliative care. I think the only person can do something alone is God. The rest of us, we need each other. In palliative care, it is absolutely critical that we work as a team, because a patient has many needs, and not one profession can provide those needs. A physician cannot be a physical therapist. A physical therapist cannot be a dietitian. A dietitian cannot be a radiologist. I mean, so it is important to work together and to have a very open and respectful communication, and having the patient as the center of what we do. I've had over 45 years of experience in physio. Yeah, I'm an old lady. But what drives me is to see a smile on a patient's face. To go to bed and say, I made a difference today. Whether someone sees it or not is not important. I know.